Welcome to Berries in the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries, and so much more. Let's dive in.
All right, welcome everybody back to In the Interim. I'm joined today by a couple of really interesting guests and a really interesting topic. I'm your host, Scott Berry. I should do that. And I'm joined today by Tanya Simuni. She is the Arthur C. Nielsen Jr. Professor of Neurology and the Director of the Parkinson's Disease and Movement Disorders Center at Northwestern University, Feinberg School of Medicine. She is an expert in the design and implementation of Parkinson's clinical trials, focused on disease modification, and the lead author of the new biological definition and staging framework for neuronal synuclein disease, where we'll talk more about what that is. And she serves on the leadership team of the Michael J. Fox Foundation, sponsored PPMI study, and it's the largest Parkinson's disease biomarker initiative. And we're going to talk much more about that, and we're going to talk about platform trial that has been generated, the first platform trial that has been generated from that. We may have more. Also joined today by Dr. Barbara Wendelberger. She is here at Berry Consultants. She's a senior statistical scientist at Berry Consultants. She's been here 9 years. She got her PhD in statistics from the University of Wisconsin, where she worked on statistical and computational biology. And she focuses a good bit on neurodegenerative diseases, innovative trial designs within neurodegenerative diseases, and disease progression modeling. She's the scientific lead for Berry Consultants in our work with the Michael J. Fox Foundation and working with Tanya on the different projects. And so welcome both of you to In the Interim.
Yeah, thanks for having us.
Thank you for inviting us.
So let's get into this. First, I want to talk about the P2P platform trial, but I think it takes a bit to get to that. And so first, I've not done much in Parkinson's disease, but what is Parkinson's disease? Tanya, can you give us the quick intro that we need for Parkinson's disease?
Absolutely. 30 seconds, Parkinson's primer. Parkinson's is the second most common neurodegenerative disease after Alzheimer's that is manifested by the clinical triad of slowness of movements, particular muscle stiffness, and resting tremor. That is the clinical phenotype that drives clinicians' diagnosis of Parkinson's disease. However, Parkinson's is much more than a motor syndrome. It encompasses a spectrum of cognitive manifestations, specifically with the progression of the disease, behavioral manifestations, impairment of autonomic nervous system, sleep dysfunction. So it's truly multi-system disorder. So far, what I told you in my 30-second primer is the clinical syndrome of Parkinson's. I haven't told you what causes the disease. We don't know that. And I have not told you what is the underlying pathology of the disease, which is absolutely relevant. The underlying pathobiology of the disease is that there is a progressive loss of cells in midbrain structures of substantia nigra and other related neurons that translate into progressive loss of production of the neurotransmitter dopamine, which is responsible for the motor manifestations. There is much more than dopamine loss, but this is the primer. And the last point is, based on what I've just said about underlying pathobiology and clinical syndrome, what is obvious from that is that there is a long lag in between onset of disease pathobiology and progression of it to the point when someone shows up in the physician's office with the first complaints of their symptoms. And the reason why I'm highlighting that, because it gets us to P2P, the opportunity to intervene before someone develops the classical phenotype. Sorry for more than 30 seconds.
No, that was great. Okay, so you talked about the clinical symptoms, the phenotype that shows up. It seems like a different kind of disease, that there may be multiple ways in which somebody develops Parkinson's. Can it be a genetic disease potentially? Can it be environmental things potentially that have caused it? We've talked about, I've heard potentially that, Agent Orange in military settings or other things, can trauma potentially cause it? So there's lots of ways in which you can come down with Parkinson's.
Great questions. As I've alluded, the course of Parkinson's remains unknown. Yeah. We carefully indicate that it is interplay between environmental causes, and under that umbrella, it's toxins exposures, trauma, and multiple other unknown factors, right? And genetic predisposition. If you look at the Parkinson's population at large, approximately 10 to 15% of individuals carry gene that is known, one of the genes, right, that are known to be associated with increased risk of Parkinson's. Not every carrier of a particular genetic variant will ever in their lifespan develop Parkinson's clinical disease, because the word is penetrance, ability of the gene to manifest with a clinical phenotype. The penetrance of a number of those genetic variants is low. But getting back to your question, it is interplay between environmental and genetic causes. There has been tremendous amount of research in both domains. There has been specific interest in genetic causes because that is something tangible that we can put our hands on and translate into targeted, personalized therapeutic interventions. The one important factor that I haven't mentioned so far is age. Out of everything that I've told you, the highest risk factor is age. As any other neurodegenerative disease, Alzheimer's disease, Parkinson's disease, the prevalence of the disease increases exponentially with the age of the individual.
Okay, so you described there's so much that we don't know about Parkinson's. Hence the work that the Michael J. Fox Foundation is doing in understanding Parkinson's, and the development of the Parkinson's Progression Markers Initiative, PPMI project, which is a precursor and a current cursor. It's certainly related to P2P. So what is PPMI?
PPMI is a seminal, largest prospective observational study that was launched by Michael J. Fox Foundation back in 2010 with a primary objective to validate biomarkers of the disease progression. Why such a huge investment into that question? Because the primary objective of the study is to enable higher success of the studies, specifically aimed at disease modification, slowing progression of the disease. And despite in 2010, it was about 20 plus years of trying. By now, it's 35 years of trying to and testing multiple molecules and intervention for slowing disease progression, we still have not reached that pinnacle. So, again, to summarize, it is the study that started recruiting back in 2010 individuals with newly diagnosed Parkinson's disease, healthy controls, later added populations, genetic Parkinson's disease, and importantly for the rest of our discussion, what is called prodromal population. People who do not carry diagnosis of Parkinson's disease, but have features and traits that we know from epidemiological data increase the risk of development of Parkinson's disease, and all those individuals are followed by with a unifying, structured protocol of the assessments that include a plethora of the clinical assessments, which are the traditional or potentially endpoints for the clinical trials. But mostly importantly, deep biological characterization of the individuals. With measures assessing dopaminergic function and collection of a number of biofluids, so that as the science develops with the biomarkers, there were samples collected that those biomarkers could be tested. And my last kind of statement would be, as I have said, for years, it was collection of the data, samples that actually, since probably 2015, every single disease modification study that has been launched by industry used PPMI data to model their studies design. Disease progression, any sample size, what population to recruit. But in the early 2020s, really between 2022-23, major breakthrough was made in Parkinson's, i.e. development and validation of a biomarker of underlying synuclein pathology. Synuclein is the protein that aggregates in those vulnerable cells. And all the data supports, while we're not making the statement that synuclein aggregation is the sole cause of the downstream cascade of the disease, all of the data supports that it is the major contributor. So for the first time in Parkinson's history, we actually are able to measure and assess biomarker of underlying core disease pathology.
Okay, so a lot there. First of all, do you know this? Do you know the number of individuals, participants that are part of the PPMI study?
I do exactly. As of last week, we have hit 4,000 individuals recruited in PPMI.
Okay.
And what is important is that retention of the participants is remarkable. Again, I've already said that the study was launched in 2010. Initially, the participants were asked to contribute the data for 5 years, but the study evolved over the years, and we have a number of participants who are still in the study, now 15 years plus.
So this incredible effort, we have this disease where we understand the phenotypical clinical symptoms. You said the second most common neurological disease, but we don't understand a great deal about how people get to that point. So Michael J. Fox Foundation creates this amazing longitudinal study to study individuals, many of them coming in maybe have certain risk factors, family members that have had Parkinson's, and so they go into this study. and following them. Probably now we have many with 10 plus years exposure, and you're getting biomarkers on these individuals. You're getting clinical outcomes of them. Now, despite this being a very common disease, it still must be reasonably rare for these individuals to then become symptomatic. But this incredible study to learn about the disease. And now that study continues, and we want to highlight the work that the Fox Foundation has done in this, in understanding the disease. And you highlighted that pharmaceutical companies that want to go into Parkinson's disease, this has become an incredible engine of information, of study design. The value of this is incredible in what they've done. But they want to do more now. And I'm going to come back to this alpha-synuclein part, which I don't understand a great deal of it. But now the notion is you've got this longitudinal cohort. Maybe we can learn about treatments to slow prevention. So Barbara, is this the notion behind Path to Prevention, P2P, study? What is that? Can you tell me what that is?
Yeah, so the Path to Prevention study that we've been working on for the past number of years is a global, perpetual, multi-center, multi-regimen clinical trial. So it's a large platform trial where we're studying the safety and early efficacy signals of various possible therapeutic options. And as Tanya has mentioned, it very much targets this early population of alpha-synuclein disease. So we're really trying to target participants who have some early signs of Parkinson's disease to see if we can really focus on prevention and identifying early signals for therapeutics.
So the platform part of this, just to sort of make it clear, is that there will be multiple regimens in this trial. I have multiple treatments simultaneously being investigated, common controls within this. Is the plan to have placebo controls?
Yes. So there are placebo controls for the different a shared placebo control for these different regimens. And additionally, we are planning to leverage information from non-randomized participants from the PPMI study. So we have participants who would be eligible for P2P, but don't choose to enroll into the platform. And so that information on those non-randomized control participants is built in to the analysis in addition to that shared randomized control information within the platform trial.
Yeah, so that I want to come back to that. That's such a neat, incredibly valuable scientific aspect of this to understanding whether any of these treatments are beneficial. But I want to come back to the patient population. And maybe I shouldn't even be calling these patients, but participants. But I think it comes back, Tanya, to what you were describing. And you were the lead author of a paper, A Biological Definition of Neuronal Alpha-Synuclein Disease Towards an Integrated Staging System for Research. So I think this is an important part of the P2P trial and who the participants are. So come back to this idea of alpha-synuclein disease. This is a marker that was developed but discovered in PPMI, which you're able to stage the risk of Parkinson's for individual based on this biomarker.
Let me clarify a couple points. Alpha-synuclein you're correct, but let's walk through that,
Yep.
Right? So alpha-synuclein is the innate protein that plays a number of physiological roles in the cells. It is present not only in the cells of the nervous system, it is present peripherally. In pathological state, it aggregates. And in aggregated form, it becomes toxic to the cells and interferes with a number of core cell functions. And as I have said, all the data supports that it is one of the key reasons for the progressive dopaminergic cell loss. For the last 100 years, right, clinicians made the diagnosis of Parkinson's. Pathologists verified clinical diagnosis based on looking at the tissue, autopsy tissue, both someone's death, and seeing two key variables: loss of dopaminergic neurons and Lewy body inclusions in the cells. And the major constituent of that is alpha-synuclein. What was the breakthrough is, so that there's clinical diagnosis when someone lives, pathology confirmation when someone passes, and nothing in between. So the major breakthrough is that there was development of the biomarker of synuclein pathology based on CSF sample using the technology of seed amplification. Michael J. Fox was instrumental in supporting the research leading to development of the biomarker, and PPMI is the largest cohort that validated the biomarker. Now, from the biomarker to definition of the population. The objective for P2P, the objective is to test therapeutics before people develop the classical Parkinson's phenotype diagnosis of Parkinson's disease. That population currently is labeled as prodromal population. Prodromal is not well regulatory accepted term. It is very non-specific. So what the biomarker discovery allowed us to introduce biological definition of the disease in living person, right? So we can test the biomarker of synuclein pathology, and based on that, we have postulated that anyone who has positive biomarker of synuclein pathology has neuronal synuclein disease, independent whether they have the clinical phenotype or not. The next core biomarker is biomarker of dopaminergic dysfunction, which today is widely available dead SPECT scan. So these are the two core biomarkers that are being tested in that pre-classical diagnosis population. And if people are positive, they have neuronal synuclein disease. They have what we have described as neuronal synuclein disease stage 2B, and provided that they meet other inclusion criteria and do not have key exclusion criteria, that is the population that we are targeting. So the novelty, the first platform study in this prodromal population, the first time to recruit the individuals based on biologically defined population and not much less specific that phenotype of prodromal population.
So that's fantastic, and I assume at this point, and I do create the analogy to Alzheimer's and about Alzheimer's with amyloid, and is amyloid a correlation to disease? Is it the causal pathway of all of that? You refer to this as staging, which I assume means that it's certainly correlated to developing Parkinson's. It's on the pathway, but we don't know if altering that would alter whether you're going to get Parkinson's, whether you could slow the progression of Parkinson's. That's a huge scientific question moving forward, I assume.
You are absolutely correct.
Yeah.
But biologically defined population is an essential prerequisite, right?
Yeah.
As statistical experts, you know that the key enemy in the studies is variance, right? And recruiting individuals with variants of underlying biology negates our ability to test the hypothesis, specifically if the therapeutic is targeting that underlying protein. It doesn't make sense that there are amyloid targeting therapies in people who are negative for amyloid, right? History has clearly shown that. Similarly, it doesn't make sense to test synuclein targeting therapeutics in people who don't have underlying synuclein pathology.
So part of this, the variance aspect of this, if we went out and said we want to do a treatment for the prevention of Parkinson's, and we don't have this knowledge of synuclein disease, synuclein staging, we might need to enroll many hundreds, thousands to get positive cases out of a placebo, out of a natural history. But now to be able to enroll this prodromal population that are positive for synuclein disease, this prodromal population, we've enriched it for much more likely to develop it, which enables us to do this P2P trial.
All accurate. Yeah.
Okay. So Barbara, now embedded within this whole structure, we've got this prodromal population. And give me a little bit about the statistical scientific structure of the clinical trial embedded within this whole structure of this. And let's assume the status of this right now is you're not enrolling you're not randomizing any patients right now. Is that right?
That is correct.
Okay. So Barbara, let's assume you get 3 treatments in here that are interested in this stage 2B, this prodromal population. What does the scientific structure of the trial look like?
Sure. So the trial is this randomized entity within our larger non-randomized cohort. And if we have 3 different arms enrolling, we're following patients for 24 to 36 months. So we have at least 24 months of follow-up on each participant. Some of the earlier participants we do follow longer, so that's the up to 36 months. We're collecting data. We have multiple primary endpoints. So we have a biomarker endpoint and a clinical endpoint. The biomarker endpoint measures this dopaminergic dysfunction that Tanya's mentioned. So that is the DAT SPECT imaging. And then we also look at a clinical endpoint, which is NDS UPDRS Part 3, which is a very common endpoint in the Parkinson's space. And so that is looking at, I believe, motor dysfunction.
You're correct.
Yes. And so what we're doing is with these 3 arms, a participant enrolls in the trial. We have a 2-stage randomization system. So first, the participant is equally randomized between the available regimens. So in this case, they'd be randomized 1:1:1 into either regimen A, B, or C. And then within that regimen, we have a K-1 randomization, which is the number of regimens. So in this case, K is 3. Yeah. We have 3 actively randomizing regimens. And so within regimen, we have a 3:1 randomization of active treatment to placebo control. And what that allows us is within the randomized population to have a 1:1 comparison of the active treated group to our shared placebo, which is shared across that A, B, and C regimen. And success in this can be a positive outcome on either the biomarker endpoint, the clinical endpoint, or both.
And roughly a sample size for an arm?
participants in an active, on the active therapeutic. So the controls vary a little bit, but 125 to each active treatment.
Okay, so if three arms were able to start this simultaneously, we have 125 on A, 125 on B, 125 on C, roughly 125 placebos at the same time. I want to come back to this fantastic aspect of you have individuals that are part of the PPMI greater effort. You presumably are going to have, before their randomization, their characterization of these individuals, but then they're randomized, and I'm sure you're collecting more regular collection for these individuals. But you also have somebody that might be eligible for this trial, continues to have their data collected in PPMI and grants the right for their data to be analyzed for this, that could be used to reinforce your control arm. And the huge thing for these 125 is what would have happened if they didn't get the drug. And you've got this additional information. This is such a unique set of data to have within the trial. So you're going to use those to enhance the control, presumably.
Correct.
That's fantastic in this whole embedded aspect within the learning. So let's think about what would happen here if we didn't have the Fox Foundation PPMI. And a pharmaceutical company, first of all, they wouldn't necessarily have this. Without this, we wouldn't have known perhaps stage 2. You wouldn't be able to do this. For a pharmaceutical company to go out and find these stage 2 patients would be incredibly challenging, I imagine. Tanya.
I will jump in. You're absolutely right.
Yeah.
Probably I would put it even more pragmatically. In the current state of affairs, that study will not be feasible.
Yeah.
Outside of PPMI. One of the objectives of P2P is to develop the learnings and bring them to the industry community to make such studies in the future reality. Because obviously, disease prevention, therapeutic trials are the pinnacle, the holy grail. We need good drugs, we need the right population, we need the right outcomes. Simple recipe, really tough to get the right cake baked, right?
Yeah. So essentially, they wouldn't have the ability to get these patients, whether they'd have even the knowledge of who they are, which we now know the knowledge of this. It would be incredibly challenging to enroll that patient population. But then, even in the simple case where they could find these patients, they all individually might need to enroll 125 and 125. And so it's 250 more patients for the community of these 3 trials to be done within this setting. And individually, when Pharma A runs their trial, that information is kind of cordoned off. It's in a study. We don't get access to that data. We don't really learn from it. All of this data goes back into this incredible learning atmosphere. So this isn't just, does drug A work? This is continuing to contribute to our understanding of the biomarkers and progression and the behavior of the disease, I assume.
You are absolutely right. It is obviously, if one of the tested therapeutics meets the endpoints, either primary or secondary, and which provides the justification for the individual company to move ahead with a further development of the drug. That would be terrific. But independent of assessing efficacy of the therapeutic, all the learning aspects that you have just indicated, right, and bringing the data to the community for further learnings, right, will advance ability first of all, advance the science and advance the ability to implement future studies. Barbara has indicated what are our components of multiple primary endpoint approach. These are the best based on the modeling and extensive work of the Berry team that I really want to highlight. Barbara, Amy Crawford, Cora Allen Sivieta, right? We've been working for 3 years by now. And if people are asking, what have you been doing for all this time, right? It takes a lot of time because PPMI is a living study. It's constantly, it's adding participants. We have new data. We have new understanding of the data that enriches our modeling. So again, but the data will become available in the public domain as quickly as we can, while the participants are propagating through the interventional arms. The data that aligns with PPMI data set still will be available on the PPMI site. For the P2P data, once the arm completes and retires, the intention is to make the data set again publicly available, aligned with overarching philosophy of the foundation, advancing the science, leading to better therapeutics for people.
Yeah. I mean, it's stunning to think about the effect this has, where we have a number of trials in fully symptomatic patients that have been diagnosed with phenotypical Parkinson's. There's a number of drugs out there looking at UPDRS as the primary endpoint. It's all of that. But this has enabled us to move into this prodromal population, this incredible scientific machine. Is this something, and I'll ask this as kind of a bigger question, why don't we do this in many more diseases?
Great question. Berry team has really contributed and largely pioneered the concept of the platform studies. And now every meeting that we go to, at least in the space of neurodegeneration, the discussions in clinical trials start with platforms, right? And Bayesian approach to the data analysis. I always add, platform is an incredible vehicle of studies efficiencies, of smart studies design. It puts the vehicle to the charge of having right cargo on top. We need the right drugs. Right drugs, right population selection. So to answer your question, why aren't we doing that in other diseases? Those are in development. It also depends, obviously, Alzheimer's is the front runner. They have major advancements in biomarkers. They're testing the therapeutics in the MCI, biomarker-defined MCI population, but also in, as you well know, in autosomal dominant Alzheimer's carriers, asymptomatic, right? So it requires, in order to move that from observational studies into therapeutic interventional studies, we need maturity, a certain degree of maturity of the biology, right? We need the infrastructure, we need the investment. And again, calling out the foundation for being really bold for supporting this initiative.
Yeah, fantastic. So Barbara, the Berry team has been working on the trial design. And Tanya talked about Cora Allen Savietta and Amy Crawford working with you on this. Ben Seville, who was previously at Berry, did some work on this as well. But you're working with a data coordinating center as well.
Yes.
And who is that?
That is University of Iowa, and led by Chris Coffey, so himself and his group. And they have been just instrumental in understanding what is in this data set and enabling the work that we have done in the trial design piece.
Yeah. Yeah.
Chris is the chief biostatistician for PPMI study, and him and his team have been supporting statistical analysis of PPMI data since inception. And you can imagine 4,000 individuals by now, 15 years since inception, a lot of data, a lot of analysis. So again, huge credit.
Yeah. So what a fantastic scientific effort. And again, I want to highlight the Michael J. Fox Foundation for making all of this go. And I'm going to be crushed for saying this, but I believe they have taken us back to the future in this. And I know I'm going to be crushed for saying that, but it's incredible effort. So Tanya, thank you for joining us. Barbara, thanks for joining. We will come back to this. We can't not have an update to this. When arms start, we want to know, and I know that this is aggressively happening to add these arms. We want to get an update on this. We want to get an update on the learning of Parkinson's disease. But thank you so much for joining us here in the interim.
Thank you for the invitation. Would love to be back. A fan of the podcast. Actually have it on my library.
Ah, fantastic. So you're the one. Wonderful. For everybody else, we will be here in the interim. Thank you.